Hello, everyone. Welcome to this episode. Shaun Brewster here with you today, and a little special guest who hasn't been on the podcast with us for a while now is Dalton Yates, who's one of ACE's educators and now based in the UK. So it's always good to catch up with Dalton. And this time on the podcast, everyone's going to enjoy listening to him, I'm sure. Dalton, thanks for joining us today. We're going to have a little bit of a chat about a topic that I've coined, which is called "Beware the Paradigm Pendulum." And this was a suggestion from you about how we sometimes change our beliefs or understanding and explanations around what we do with our patients, and how sometimes swinging that pendulum around our beliefs and the way that we communicate those beliefs and ideas to our patients can sometimes put us in hot water if we aren't careful, if we swing that pendulum too far. And so it's from one extreme to another that can leave us looking a little worse for wear, but also leaving the patient feeling a little bit lost in their understanding of what's going on for them in their presentation. So talk us through this concept, through this idea from your perspective, and maybe give some examples.
Yeah, for sure. It's one that I think comes up for us quite often when we're in courses. We talk about this idea of not swinging the pendulum too far. And um, sometimes I know for myself, I've thought that I've been hitting the nail on the head anytime I'm having a discussion with patients or with other therapists. And then it's not until some months later that I realize that I was actually quite far off where I should be with those conversations. So it's one that's important, I think, to always have a bit of reflection to address. And um, when I sent through this suggestion to you, it was after I'd just done a bit of reflection on a few treatments that I'd provided early on in my career. This is when I was back in Australia at a clinic, so I haven't got any clinic notes to share specific details, unfortunately, but I remember the basis of one in particular. And it was a patient that had been at our clinic many a time, seeing a lot of other therapists, just sort of bouncing around between whoever was available. And he came in to see me the week before he had an Ironman event, and he's been dealing with some plantar foot pain for quite some time. And from what I remember, I think it was one that he had episodic. It came and went for various months. And uh, like I said, this was quite early on in my career, just down a remedial massage training. So I was very biomechanical minded, very muscle minded. I wasn't even aware that nerves could cause pain at the time, or that you could have pain from joints. All I focused on was just trigger points. That was the answer for any type of patient's presentation. So that's exactly how I treated this. I had the idea that we need to release knots in his calves and lengthen the tissue, strip it out, make it longer, and have less tension in the plantar fascia of his foot. And that's what's going to reduce his pain. That's actually the opposite of what you would expect now. We know that if we have reduced tension in the plantar fascia, that would be what's increasing a patient's painful experience. So quite the opposite of what you would say is now evidence based. But after I gave this patient his treatment, he got up and he's nothing but praise for me. He was very happy with the outcome. He had immediate pain relief in his foot, and he went on and competed at his event and didn't have any dramas. Um, he came back a few months later, and this was enough time for me to have got a few different courses under my belt, read a dozen or so studies. So I thought that I had a pretty good understanding of pain now and a pretty good understanding of mechanisms behind manual therapy. So he's come back. Wasn't an Ironman, but he had another event on. I think it was just like a 10K run or something like that. And he had the foot pain again. So he's asked, that last treatment you gave me was amazing. I wanted to come back to you specifically to have that same treatment. Can you just massage through my calves, lengthen the tissue? It's feeling really tight and restricted, and it's pulling on my heel again, and that's what's causing the pain. And I took a minute and I sort of just stopped him right there and said, well, let's just have a bit of a chat about that. And I have to apologize. That's actually quite outdated information. And I may have gave you the wrong understanding of your pain and of your presentation by saying that initially. We spoke about that for a while. Uh, And I can only imagine that he was probably quite disengaged in that conversation from his previous understanding and how I had previously spoken to him so confidently that that was 100% the case and it couldn't be anything else. And now I'm saying the opposite. And I didn't actually go down the same path of treatment for this patient. I didn't provide the same massage that I did through the calves and over the foot. I went through a couple of joint mobilizations for the heel, and I believe I'd done some dry needling. And then we got him up off the table and got him to go through a few exercises, some calf raises, and various different ones. And he still said thank you, still said that was good, but there was definitely a change in the tone of his voice. It wasn't as excited. He wasn't bursting to get up and shake my hand and give me a high five after the treatment like the first time. This time it was pretty quiet and didn't hang around very long. Left the clinic, paid, and I saw on our clinic schedule a couple of days later that he was back in again, this time seeing the previous therapist that he saw before seeing me the first time. So obviously it didn't quite do the trick for him like it did the first time. So yeah, I wanted to go through a few different possibilities of why this could have been the case, the different contexts of the two treatments, and the possibility that maybe both treatments could have provided as much relief. Just the way that I communicated it at the time could have been done a bit more tactfully, and yeah, learn from those experiences.
That's a really good reflection and a great way to frame it up with that story, I think. And we're probably almost definitely all of us have been guilty of doing this at one time or another, where we've come in and a patient has come back to see us several times sometimes and believe that we are the person that can help them. And then one day our story or our paradigm shifts to something new and the patient gets left behind, don't they? And I've
Mm,
often used this idea of beliefs around manual therapy and other modalities that we use as being almost like a religious belief. You get so entrenched in this thing. Like if you're a physiotherapist, you think like a physiotherapist. If you're a massage therapist, you think like a massage. If you're a chiropractor, you think like a chiropractor. Like that's there's a way of believing and thinking and acting and that and yeah, I guess being that person. And then along the way, we'll learn, like you did in your example, we'll learn new things, we'll read new things, we'll be exposed to new things. And our belief, our religion, changes gradually, progressively as we get more information and we start to develop new ideas and develop new beliefs. And so that gradual progression happens over time. But when you have a patient comes to see you and you've been the massage evangelist and you've been, telling stories and all and giving sermons about the benefit of what you can provide, and then suddenly they come in and you go, actually, no, now I'm a something else evangelist and I have to tell
mm,
you a different story. It's like, well, who is this person? And it's no wonder that they would lose faith and trust and rapport because they had the faith and the trust and rapport because they believed wholeheartedly in what you believed the first time around, that explanation. And the second time around, they didn't get the journey. They didn't get the story, the gradual building up of new ideas and beliefs. All they got was the new idea and the new belief with no journey in between. And so it's logical, isn't it, that a patient could be left feeling a little bit high and dry and like, well, hang on a second. You did and you told me this other thing last time and I felt better and it worked. And now you're telling me that's wrong and it's outdated and it doesn't work and you want to do something different. And so, yes, of course, of course, that swing and is it swinging the pendulum too far or is it swinging it too fast? Maybe that's what it is. Maybe that they just they can't keep up with the pace of that change. Maybe what you did in that second treatment was the right thing to do, but because he didn't have the contextual understanding or didn't have the belief that you had that you gave him the first time around, he didn't have the contextual factors, the psychological factors, the emotional factors that were embedded within him the first time to get the same effect. And we know that so much of the beneficial effects from treatments come from patients' beliefs in us as an individual, as a clinician, in trusting in our ability through the rapport that we've built and the explanations that we provide them. All of these things build towards good outcomes. It's not just what we do with our hands or our tools, it's the other stuff too. And this is a perfect example of that because I believe that if he came to see you the first time and you did what you did in the second treatment, there's every chance he could have got the same benefits that he got in the first one from the second treatment, but he was possibly left behind the pendulum, not being taken on that journey with you. So I think that's a really great example, Dalton. Thank you. That's great.
Yeah, most definitely. I couldn't agree more with what you said there about it's not possibly the pendulum swinging too far, but it's swinging too fast. And that's what I guess would share from having that change in paradigm. I initially did have some of these situations where I saw patients in the past, and what I'd done previously worked, and what I'm doing now doesn't work. But for any new patient that I saw, when I had that sudden change in understanding beliefs, paradigms in manual therapy, I was still having as many beneficial outcomes and interactions as I was previously, because they didn't have, I guess you would say, like a baseline established of myself as a therapist. And it still came across the same way as I was in my previous experiences. But it was just now with different tools, different understandings, different language, but the same level, I guess, of confidence in what I was doing. So yeah, it's that idea that I guess that you mentioned really well, that pendulum traveled too fast in that one appointment with that patient. One thing that I really like that we talk about at a lot of courses, especially in the dry needling courses, is the idea of dosage and doing the right treatment, the right dosage for the right patient at the right time. And I guess one thing that we could now add on to that is the right communication or the right amount of communication for that patient, because that's one that I've heard from a lot of therapists is they've experienced better outcomes as they've become a better communicator. And that's one thing that we need to focus on, I guess, is that right communication or the right language for the patient at the right time,
Yeah.
telling him that all of that information was outdated and we're not lengthening tissues. And the idea, if that was the case, we always give the example: you lean up against a doorknob and you'd fall over because you just release your glute med, and you've got no stability anymore. We're stronger than that. But telling a patient all about pain science and our current understanding is probably a bit too complex to do in a 30 minute or 1 hour appointment, when you've previously been telling them different ideas.
Mm, definitely. And this we see this play out with students as well. I remember an individual student many years ago who came into a classroom and I was talking about back pain from spinal origin and disc bulges and alike and causing chronic back pain. And this particular student um, had a disc injury in her early 20s, I guess, as an elite tennis player, and went on to had to give up the sport because her back pain became so debilitating, and believed into her late 30s that the disc injury was still the source of her pain. And now we know that that can't possibly be true. There may be some involvement with the disc over long periods of time, but typically disc injuries heal themselves quite well over relatively short periods of time. The pain, though, can linger for much longer than that, and it can be from other origins. And so in this class, I remember doing what you did with your patient. I remember sitting down with the classroom talking to them about these concepts. And for the most part, the class were like, wow, this is incredible stuff. I really, I'm buying this. I believe in it. And it seems very logical and useful. We'll be able to use this clinically. But this one student who had had a very personal experience with her back pain over many, many years just closed down completely. I remember her sitting at the back of the room with her arms crossed and was almost just shaking her head as I'm explaining these concepts, because she's like, no, I'm proof that that's wrong. I had this disc injury and it's been sore ever since, regardless of what I do. I have a scan here from 18 years ago that shows the disc bulge, and I had that pain then and I have that pain now, and here we are. So you're wrong. And I almost had to have an intervention with her to to bring her down off the roof, to sort of say, you know what, your back pain might not be from what you think it's from. It's absolutely real. It's real pain. You're not imagining it. You're not making it up. It's not in your head. But it may not be from the original source that produced it, almost 2 decades ago. And that took quite a while. And over the course of that semester, I was teaching at college at the time. Over the course of that semester, I saw her beliefs change because she got to catch up to the pendulum. And as she got more information, she got a better understanding. And over time, she bought into this different belief. And I haven't seen her for many years now, but I'd like to think that maybe that change in belief and paradigm for her has allowed her to have some change in her experience of pain. I don't know. I can only cross my fingers and hope that's the case. But in that moment, I too swung the pendulum too fast for that individual. She wasn't ready to hear it. And I think we sometimes, as clinicians and as educators, get very much caught up in the idea of truth telling. We have to tell the truth. What does the research say? What does the science say? What does the evidence point us to? That's the only thing that we have to focus and should focus on. But we forget sometimes that the people we're telling it to are human beings, and they have a history, beliefs, their own story, their own understanding about their body and how it works and what's brought them to where they are today. And we come back to this religion idea versus, just concepts and ideas. Try to tell somebody that their religion's wrong. It's a dangerous line to tread, and so you have to introduce concepts and ideas to them and allow them to make up their own mind over time. And some of them won't get there with you. That's the thing to remember too. Some patients wholeheartedly believe in a particular paradigm because they've seen the results, like your example before. And so trying to change their mind might be a waste of their time in that session. I think it's useful to share information, absolutely, but do it at a pace that they're comfortable with, and do it in a way that they can actually receive the information and absorb it and use it, rather than build that wall, reject it, waste their time, waste your time, and get you both nowhere.
Yeah, and that's one that we have so common in our courses as well, because we have quite a few different ideas that challenge people's belief in not just that modality, but more so the industry quite broadly. So we often have a student just like the one that you experienced that's up the back with their arms folded, thinking, "Hang on, I'm not quite buying into this, and I've got 2 more days to listen to these guys talk about." What they're trying to sell to me. And then slowly, after having a conversation with these people at a personal level, that's where you start to understand their perspective. And all of a sudden, it's like a sudden click. They buy into it. They can not necessarily have an immediate switch of believing everything, but they've got the time to listen now. And that's where you have as much growth as possible, I think, is when you're both understanding each other.
Mm.
Investing in that time to understand someone else's perspective is going to be one of the best ways for you to get outcomes for your treatments, no matter what sort of paradigm you're working with or what tools you're using in your treatments. If you invest the time at the start to understand what your patient believes about their presentation or their pain or what they believe they need to get better, and then you can provide something and inform them along the way of the various different ways that they could achieve that goal, then you'll have a much more beneficial outcome. And like you said earlier, when you responded to my story about if I had have done this second treatment initially with this patient, or even if we took some of the contextual factors away, it'd be as beneficial for the patient. On reflection, if I could have gone back and done that treatment again, instead of saying, no, that's wrong, we're not doing a soft tissue massage, we're not lengthening the muscle to make your foot better, we'll get you doing some exercise and that'll lengthen or that will decrease pain, provide some post-exercise pain relief. If I had have said, yeah, one option is we could massage through the area, that'll give a bit of a pain relieving effect. That'll also potentially have various changes, or we could also get you doing a few repetitions of a calf raise or a Romanian deadlift, and that could also have as much benefit. Or we could also get you just going for a walk, and that could have as much benefit. We could do a joint mobilization, and then let them take a bit of ownership again of what they'd like to do now. And you might go into a bit more detail explaining how the mechanisms behind some of those various options work if they show a bit of interest. But it's a big change between saying, no, that doesn't work, we're not doing that, and losing your patient or losing a student right away versus giving them informed consent basically to choose between their treatment modalities.
Mm. Getting that the patients buy-in, and they're getting their story around what they believe will help them. To your point, is a really good one. got me thinking about probably one of the best books I've ever written. I wish I wrote this one. One of the best books I've ever read, which is called Seven Habits of Highly Effective People, Stephen Covey. And he says in that book, one of the habits is seek first to understand, then be understood, which it's always stuck in my mind. It's like, that's such a good one. Because when you're with a patient or with a student, if you don't first seek to understand them, their
Mm,
situation, their understanding about what they believe is going on for their body, their beliefs about what will work for them in a treatment, if you just come at them with what you know to be true and try to give that to them, one, they may not be ready. Two, it might be in opposition to what they, you know, systemically believe about themselves. All of these things can just be brick walls to them. So seek first to understand, then be understood. So is what you're saying. You build that rapport, build that understanding,
mm,
get to know them, what they want, what they believe to be true, and then say, well, actually, you can impose that. You can say, I hear what you're saying. That's really interesting because here's what I've experienced, or here's what I used before, and this is what's worked well for me. Would you be open to that? And then you can read the room. What are they like with that information? If they're like, I actually just came here for massage. I always get a massage before a triathlon, and that usually solves the foot for about a week, and that's all I need. Well, I can do that. That's fine. We can do that for you. Now, if you want some other things, here's some other options. But today, sure, let's do that. If if you as a practitioner are comfortable with that, then that's a useful thing to do for somebody because they have a strong belief about effects. They've got a historical reference point to say that it works well for them, and all of those things will probably lead to them having a good outcome for that treatment. It might not be the best thing that the research says you should do. It might not be the best thing that your experience says you should do, but it might be the right thing for them in that session. And then you can drip feed these other ideas and maybe lead them down a longer term view for some outcomes that might get them the better results in the long term. It's because you're leading them, not shoving them that direction. I think that makes the difference.
100%. One thing that I just thought of as you were going through that as well is couldn't agree more with how effective it is to seek to understand first and then be understood, but also how much more efficient it can be. When you ask someone or get them to explain their understanding first, you then know where you can start with your explanations, what sort of language to use, and what you might need to cover first before you can go into a particular topic, such as pain science or mechanisms in manual therapy. Um, and that's where I sort of missed the opportunity in this example is I just made an assumption of this is where we're going to start our conversation. Not only was that ineffective, it was also inefficient because I was going through so much information that I probably didn't need to cover. And then the more you talk, the longer you go on with your explanations, the less, I guess, someone can absorb proportionately for how much you're saying. When you keep it nice, short, and concise, they're going to retain a lot more of that percentage wise, I guess, at least. So, yeah, it can be a lot more efficient in your explanations because you know where to start from.
That's a good point. Time efficiency and efficiency
Mm,
of adoption of that information. Both of those things are really important. I think there's another layer to this too. We're talking about the individual understanding between us and the patient, but there's also the story that goes on in the back of the patient's mind about past experiences with other health practitioners. So, for example, they've been to see another practitioner who's given them a different paradigm, a different story around why they're getting pain and the things that they need to do to get results. And then we come along and tell them something that's in opposition to that. And then so immediately the patient's stuck in this situation where they are going to jump over one fence or back into the other paddock, and they don't know which way to go because one story is apparently wrong. You can't
mm,
have two right stories. In actual fact, you can. Both options can work. Both things can produce results. But when somebody is selling an idea wholeheartedly and another person says, "Well, that's not necessarily correct. This is the way," that leaves the patient in a very tricky situation. And it also makes us potentially look quite bad in a professional context because we are then telling them that this other person who we don't know may have provided a perfectly clinically logical explanation for something is wrong. And so
mm.
our professional ethics then come into question. So we do have to be quite careful how we tread that line, I think, about saying something is incorrect or outdated or old ideas or it's just plain wrong, that's also like saying all those people over there that said that to you or who have said it to you in the past are wrong. And I don't think there's a single professional association, ethics board, or any kind of organization out there that would look at that and go, well, that's okay, because it's not. You can get yourself into very much hot water um, using that kind of language about other practitioners. Now, you might not say that directly about a person, but if you say it about an idea and a person has perpetuated that idea previously, then you are saying about that person in an indirect kind of way in the mind of the patient. And that's something to be aware of, I think.
Definitely, and it could very well be the fact that those therapists that your patient saw before you that had those ideas have the same understanding as you, but they're just focusing on the patient. They've got the patient first and looking at treating and incorporating the patient's decision in their treatment choices. So maybe they're not as wrong as what I once thought when I was at that stage, and what many of us, I'm sure, would be experiencing. So yeah, it's a good point.
Yeah, this is such a useful conversation, I think, and I think for a lot of our listeners who have been listening to the past half dozen or so episodes where we've been talking about really being quite clear about old ideas versus new ideas and changing our
Mm,
language and updating our models of thinking and explanation with patients. This is a nice balancing conversation, I think, to help us remember that yes, we should be pushing ourselves forward with our understanding and our knowledge. We should be updating our beliefs and our clinical reasoning around things. But we have to remember that that pendulum swings at one speed for us and potentially a different speed for those around us. Sometimes those around us are the patients, sometimes other clinicians that we work with, sometimes they're students in a classroom or colleagues. And we have to remember that that pendulum swings at different paces and different speeds for different people. And if we want to share new ideas that we have or new knowledge with people, we've got to do it in a way that is acceptable to those people. And for some people, they're just not ready, and that's okay. And you can do what you did for the last 10, 15 years previously to today because you got results. And you could continue to do that too if you wanted to. But again, I guess it comes down to then you balancing this idea of who are you now? What do you believe now? Where do you want to go with your knowledge and your career and your development as a practitioner? You'll have a
mm.
trajectory, and then you either take people with you or you leave them behind. And that can be really confronting. Dalton, you remember this, we've had conversations with students in classrooms many times when they learn a new thing. And like a good example is our functional release cupping course. It's a very different way of using cupping and movement and a real vast movement away from passive interactions with manual therapy into much more active and dynamic approaches, progressive approaches. And we at the end of the course we'll go, oh, that was amazing, love it, I want to use it, I want to use it. And then they stop and think, and they go, oh, hang on a second, I've got Mavis coming in tomorrow, and Mavis is used to just laying down and we have a chat for 45 minutes and I put some cups on her and do some massage and things. And um, she might not be up for this. And you see them have this crisis of paradigm, this moment of like, oh, I know who I am now and what I want to do, and the things that I believe to be true have changed. But my patients, I don't I don't know how to get them there with me. And you can see them having this crisis. And I always say to them, well, try the new stuff on the new patients because they don't have a different that they
Mm.
have no, like you said, baseline. They have a different contextual point of reference. So do the new stuff on the new people, and then over time refine your explanations, refine your way to explain these new ideas, and then you drip feed that to the patients that you've seen previously, and they can then go on the journey with you rather than just hitting them with a hammer and saying, "Hey, we're going this way now." And so I think this crisis of paradigm is a thing to be aware of too as a practitioner. Um, of course, be true to what you believe to be correct now, and that changes over time. But remember that your now and somebody else's now you will arrive there at different times, at different paces.
Yeah, spot on. And that's one that I guess is another personal experience that I've gone through is having those updated uh, options in my manual therapy career, and then thinking this particular patient won't be very interested in getting up and doing some functional release cupping the way that we do. having them go through various phases of movement and then starting to play a bit of a game. Anyone that's been to the course, I think, would have a bit of a highlight, being when we're working the superficial posterior chain and getting them to play that tag game, touching your hand as you're moving it around, challenging them to extend a little bit further, or flex a bit further with their movement. And yeah, that was one that I could not wait to use in clinic, but just found it difficult to approach with patients. And until you sort of just jump in the deep end and ask a patient, would you be open to trying a bit of cupping? We'll get you doing some movement based on the activity that you're presenting with, whether it's pain as they're reaching overhead. We'll replicate that movement slowly. And yeah, vast majority of the patients that I thought wanted to come in and just lay on the table, all of a sudden we're saying like, oh yeah, that sounds fine, that's good, that sounds like a good idea. And yeah, again, it's another example of seeking to understand first. Ask the question to your patient, engage where they are at that point in time, and then you can decide whether it's something that you can go ahead with or not. Yeah, it's quite a simple process, but it can be very confronting as the therapist initially.
Yeah, 100%. It's good advice, Dalton. Thank you so much for bringing up this topic. I think that's going to be really useful for a lot of people. Hopefully, some of the stories we've shared and different ways of viewing things give everyone listening a little bit more, hopefully, a little bit more confidence and hope that you can change the way that you practice over time, and that's a good thing to do to evolve your knowledge and understanding around things. And then just being mindful of the pace of that change for you versus the people that you're communicating it to around you. I think that's really important. So thank you, Dalton. Thank you for tuning in, everyone,
My
for listening.
pleasure.
Dalton, you are 9, 11 hours difference to where I am currently. So thank you for getting up
Yeah, 11 hours behind.
early, late for me. Thanks, everyone who lives somewhere in between those two time zones for tuning in. And we'll catch you all on the next episode. Cheers.
Cheers.